Good afternoon. Sorry for the delay on the previous sessions. So welcome to this session, which is part of the ESC Cardiology of Tomorrow track. This session is entitled Future Targets in Systolic Heart Failure, the role of pharmacological therapy, new artificial hearts, complete cardiac regeneration therapies, and upcoming device. The new thing about this session is that it is being broadcast live to all over the world, so we would like also to welcome our internet audience. And we have a web moderator here, so people at home can ask questions using either the chat or the Twitter to the web moderator, and then he will send us the questions to us. So I would like to present also my co-chair.
My name is Stefan Anker. I have the great pleasure to do this together with you. And I'm told that there is currently 600 people online, and after each talk, we will show the number of people who turned off during the talk. And but no, joke, sorry. Maybe turned in, I don't know. But it should be fun, I hope. And actually, we have a web moderator. Maybe you introduce yourself as well.
Hello everyone, I'm Rafael Vidal. I'm very happy to be here and open to receive all your internet questions.
Good, then let's start.
Okay, so it's my pleasure to introduce. It is my pleasure to introduce the first speaker, Professor McMurray, who is going to talk us about pharmacological therapy in systolic heart failure, from past therapies to the new guidelines. Is there still a place for improvement for the future? We still have some technical details.
Well, John, you can give the talk even without,
without slides.
Well, we call up John and Magdi and the other panelists and started the chat anyway. Yeah, and probably would be the most exciting ESC session if we skip all the talks and just have a panel discussion.
The other way around.
Shall we do that?
How much time?
What is the estimated time of arrival? Magdi, you're up to it?
Well, we could argue about whether or not there are any.
Yeah, well, come up. Can we ask the web moderator whether we already have some questions from the internet?
Not yet. It's too early.
Why is not somebody going to the microphone and just ask something?
Okay, it's up. It's red.
Are we done? Excellent.
So it's an interesting way to get your adrenaline running. So. Okay, so I'm going to talk about possible future prospects for pharmacological therapy for systolic heart failure. So I'm very deliberately not talking about HFpEF. These are my disclosures. So I'm going to do some crystal ball gazing, and that's always a bad idea because lots of much smarter people have crystal ball gazed in the past and got it dramatically and completely wrong, as you can see from some of these. I particularly like this one where Decca Records rejected the Beatles because they said they didn't like their sound. Guitar music was going out. So I've decided to take an alternative approach, and I followed the thoughts of a recent and great American philosopher. And I'm going to focus today on what are the known knowns, and by the known knowns I mean clinical trials that are underway in humans, and I'm going to focus, as you'll see, principally on phase 3 trials. Now, where do you get information about this if you're interested in what's going on in terms of development? Well, a great website for this is clinicaltrials.gov. As you know, every new clinical trial has to be registered. Most of them are registered on this particular website, although there are other websites, so I have to say they're not nearly as easy to use as clinicaltrials.gov. So what's in the pipeline for drugs in systolic heart failure? As I say, I'm going to focus on morbidity mortality trials, but I will also mention some phase 2 trials and even phase 4 trials along the way. So this is the sort of output that you get if you search. So I searched here for trials in heart failure that are currently recruiting. I was only interested in interventional studies, obviously ones with drugs, so I've picked those out. I'm interested in phase 3 studies, and realistically most of these studies are funded by industry, very few by any other organisation. And then here you see the sort of output that you get, and in fact it's quite a nice check because these were most of the studies I knew about, though there was one came up that I didn't know about. And one of the things about drug development is, even though we like to think it's usually very exciting and dramatic, it often isn't, and usually it's actually a small step rather than a giant leap forward. And actually one of the focuses of heart failure therapy, pharmacological therapy, for a long time has been the renin-angiotensin-aldosterone system, and we're still trying to do better than we've been doing with ACE inhibitors in mineralocorticoid receptor antagonists. And one of the ways that we're trying to do better at the moment is using direct renin inhibitors. Now, this is a bit of déjà vu because we know about ACE inhibitors. Recently we had the whole ARB story. Now we've got renin inhibitors. I have no idea whether these are the same or different or whatever, but we will find out, and that's the beauty, I would say, of heart failure, because we really have a remarkably evidence-based subspeciality in cardiology. And we've got this great trial called Atmosphere, which is currently running, in which all patients are randomized to the gold standard dose of the gold standard ACE inhibitor, enalapril 10 milligrams twice a day, or to aliskiren, a renin inhibitor, or to the combination of the two. So this is an enormous 3-arm, event-driven clinical trial. It's already enrolled over 6,000 patients, and it will tell us whether or not there's a better way to block the renin-angiotensin system, or specifically the effects of angiotensin II. Another new approach is seeing whether we can better the current mineralocorticoid receptor antagonists that are available to us. Spironolactone and eplerenone have both proven to be beneficial in patients with systolic heart failure, indeed remarkably so, but there's a whole new family of MRAs under development. These are non-steroidal MRAs. The idea behind these drugs is that they target non-renal tissues, the heart, the blood vessels, more selectively, that they're more potent. They won't have the renal side effects, and in particular the concern about hyperkalemia that we have with the mineralocorticoid receptor antagonists we currently use. And as you can see here, there already is a program of phase 2 studies actually have been completed with the lead compound in this class in heart failure, a Bayer compound. And this compound's already been studied in small numbers of patients with mild and moderate chronic kidney disease in addition to heart failure. And there's even been a study comparing placebo spironolactone and this new compound. And that development program is continuing further. So there's new developments going on in this area. Now, what about blocking the angiotensin receptor? That's the other option. Well, this isn't quite an angiotensin receptor antagonist, but that was the easy way to fit it into this presentation. This is a compound that acts both as an angiotensin AT1 receptor antagonist, as well as a compound that activates another pathway that may bring about beneficial effects, particularly renal effects in heart failure. That's been demonstrated in an animal model, and there's currently a small phase 2 clinical trial underway with this compound in patients with heart failure. So far I've talked about blocking the neurohumoral systems that we know are bad and trying to refine that and do better than we've already done. But an alternative approach is to go beyond that and to think not just about inhibiting all these bad systems, the renin-angiotensin-aldosterone system, sympathetic nervous system, and so on, but at the same time to augment the endogenous neurohumoral systems that are likely to be beneficial in heart failure, that have vasodilator effects, that promote sodium and water excretion, inhibit abnormal tissue growth. And of course, the prototype substances in this category are the natriuretic peptides. And we know the natriuretic peptides do all of the things I've mentioned and more. For example, augment parasympathetic nervous system activity. And we have a new approach to doing what I've just mentioned, that is trying to simultaneously block the renin-angiotensin system while augmenting the effect of natriuretic peptides. And that's with a class of compounds that have been labeled as ARNIs, angiotensin receptor neprilysin inhibitors. Neprilysin, also known as neutral endopeptidase, is the enzyme that breaks down natriuretic peptides. When you inhibit neprilysin, you augment natriuretic peptide levels. And the lead compound in this class doesn't have a name yet. It's LCZ, or if you live in the US, LCZ 696. And this is a single molecule that is both an angiotensin receptor blocker and has a neutral endopeptidase inhibitor prodrug. You've already heard at this meeting some preliminary work with this compound in patients with HFpEF, but there is actually a very large double-blind active control trial called Paradigm Heart Failure running in patients with systolic heart failure. This is a trial, again, in which patients are randomized to the gold standard, enalapril 10 milligrams twice a day, the ACE inhibitor used in the SOLVE treatment trial, at the dose used in the SOLVE treatment trial, and the comparator is LCZ 696, 200 milligrams twice a day. As you can see, again, this is an event-driven trial. We anticipate enrolling about 8,000 patients. This trial is enrolled remarkably well, and we hope to complete enrollment by the end of this year, and maybe at this meeting in about 2 years' time present the results. Now, natriuretic peptides act, amongst other things, by activating or increasing tissue cyclic GMP, causing vasodilatation, and so on. And of course, there are other ways of augmenting intracellular cyclic GMP, and one of those other ways is to inhibit the enzyme that breaks down cyclic GMP, phosphodiesterase type 5, or one of the type 5 phosphodiesterases. And of course, a class of drugs that we know well that do that are drugs that were originally used for treatment of erectile dysfunction, but there are now a number of trials underway using these agents in patients with heart failure. There's been a lot of work with sildenafil, small studies. I know Kenneth Dickstein's doing a study. There's even a study in HFpEF, which I'm not talking about. This is an Asian program of 2 studies looking at both systolic and diastolic heart failure, but by far the biggest trial is one that has just been funded by the NIH, which is a 2,000 patient study in patients with low ejection fraction heart failure and pulmonary hypertension. So a lot of interest in modulating intracellular cyclic GMP. Now, the one trial that I didn't know about and which I found on clinicaltrial.gov was a trial using this agent. And I'm not a scientist, I'm a clinical trialist. This figure scares me looking at it. But I do know that we use a drug to treat breast cancer, Herceptin, that it's an antibody that blocks this mediator. And of course, you can think of this agent as something that does the opposite of Herceptin, reverses the sort of changes brought about by Herceptin. I was very surprised to find that there is actually a relatively large trial being conducted in Asia, 1,600 patients with low ejection fraction heart failure who've been treated with this agent. Now, it's not the easiest drug to give, as you can see here, and I understand that it has lots of adverse effects that are not very pleasant, but nevertheless, this is a trial that has apparently started earlier this year. It looks to me to be very underpowered, but I don't know all the details of it. There's no design paper published, but it is said to be a mortality trial, so that was something new. So two of the studies I mentioned, atmosphere and paradigm heart failure, are doing one of two things that I think are an important development in new drug development in heart failure, and that is really not just trying to add more drugs on top of existing drugs, but actually trying to replace some of the current gold standards. And another new development is the treatment of comorbidity in patients with heart failure rather than heart failure itself. And the best example of that is the treatment of anemia in patients with heart failure. And of course, we're doing that presently in a trial using an erythropoiesis stimulating protein, in particular darbepoetin. That trial is RED-HF. It's a trial that's completed recruitment and indeed has just completed follow-up. So this trial is being closed out, and we'll get the results probably early next year. And this will tell us whether or not this treatment, which increases hemoglobin, might also improve outcomes. Now, this is another approach, not just to treating anemia, but also treating something that's also very common in heart failure, which is iron deficiency. This is a paper from one of our co-chairs today, and this moderate-sized study showed that intravenous iron improved a number of measures, functional capacity, quality of life, and so on. And there are two confirmatory trials being undertaken at the moment, and that will be very important because I think if you have two independent studies that show that a treatment has a beneficial effect, even if it's not on morbidity, mortality, that's potentially of great importance for our patients with heart failure. What else is going on? Well, we know that atrial fibrillation is very common in patients with heart failure and places patients at risk of stroke. We know that even without atrial fibrillation, patients with heart failure at increased risk of stroke. We know that there are lots of new oral anticoagulants around, and although some have been tested in atrial fibrillation, none have yet been tested in heart failure, but I understand through the what might be called clinical trialist grapevine that it's likely that there is going to be a large randomized trial in patients with heart failure, recently hospitalized patients with heart failure, to see if one of these agents can improve clinical outcomes. The other comorbidity that is extremely important in heart failure, and in a way I'm surprised hasn't been the target of more therapeutic interest, is diabetes. Heart failure increases the risk of developing diabetes, and patients with heart failure who do have diabetes have a particularly bad prognosis. And of course, many of the existing therapies for diabetes are problematic in heart failure, most notably the glitazones. So there is some interest because of the cardiovascular effects of the incretin-based treatments for heart failure, and there are a few small proof of concept studies underway. For example, there's a trial with vildagliptin compared to placebo in patients with systolic heart failure, looking at left ventricular remodeling, safety and symptoms. There are other compounds that ought to be of interest in heart failure. For example, the SGLT2 inhibitors, given their diuretic effect because of their mode of action. So what about looking ahead for other therapies for chronic heart failure? And this is where we really get into science fiction. And of course, one of the science fiction prospects is gene therapy. And one small study has already been undertaken using a particular type of gene therapy to try and increase SERCA2A activity. This is adenovirus-delivered SERCA2A. And there is now a second trial getting underway to see if the apparent beneficial effects of this approach to treatment can be confirmed. There are other approaches to gene therapy at the moment, and this is one of them. This is a relatively small study that involves intramyocardial injections, so that's always interesting. It will be of interest to see what this shows. And then, of course, there are other small molecule approaches to treating heart failure. Now, I've finished by saying something about acute heart failure, because most of what I've talked about has been in chronic ambulatory heart failure. And I have to say, acute heart failure has been a bit of a nightmare so far, and we haven't made really any progress at all. There have been some interesting preliminary data with this compound, probably better known for its physiological role in pregnancy and preparing the birth canal for delivery, but relaxin has other actions, and these are of interest in heart failure. A relatively small proof of concept study seemed quite positive, and a larger study, relaxin AHF, has just recently completed, and we'll get the results of that in November at the American Heart Association. I've already mentioned interest in natriuretic peptides. There was a large study recently completed with naseritide that showed a statistically significant improvement in dyspnea, but it wasn't thought to be clinically significant. But nevertheless, interest in natriuretic peptides continues. This is another natriuretic peptide. Naseritide is human B-type natriuretic peptide. Urodilation is a structurally similar but distinct molecule. It has a different profile of action, maybe has more renal effects, and that is now being tested in a large phase 3 outcome trial in patients with heart failure that has recently recruited its first patient. And there are smaller studies underway with other natriuretic peptides. John Burnett in the Mayo Clinic and colleagues in conjunction with a company have developed what might be called designer natriuretic peptides to try and enhance some of the actions, reduce some of the other actions. One of them is CDNP, and there are some moderate-sized phase 2 trials underway with this particular compound. There's also been interest again in acute heart failure in alternative ways of increasing cyclic GMP, though as I understand it, these might be on hold at the moment. Of course, we've had a long-standing interest in inotropes, and to date we haven't been very successful with these. There's still some interest in levosimendan. This compound, I think, hasn't got much further, but probably the inotrope that is of most interest at the moment is this compound, omecamtiv mecarbil. Caused a lot of interest when its mechanism of action was described in the scientific literature recently, and what it does is really it prolongs systole. It's not an inotrope in the sense that I would normally think of an inotrope. It prolongs systole and doesn't increase myocardial oxygen consumption. There's no increase in intracellular calcium, so it doesn't have the actions that we believe were detrimental with the other inotropes that we've used in the past. So there are, again, some fairly large studies. There's a single large study underway with that drug called atomic heart failure. But I do wonder what it is that we've been trying to do in acute heart failure. It's all very well trying to improve symptoms in a patient who's recently hospitalized. That's a hard thing to do because diuretics and nitrates do that very well. And maybe what we really want to do is to try and improve outcome in patients after discharge, because really once you've been admitted to hospital and you go home, there's an extraordinarily high instance of morbidity and mortality in that early post-discharge period. And I think a really novel study that has addressed that very question, tried to cover that period, is the Astronaut trial. Again, a study that is either currently closing out or is just closed, and we'll hear the results soon, which tried to intensify renin-angiotensin system blockade in patients during an admission, covering that short period after discharge to see if outcomes could be improved. Now, I've given you a quick race through all the things that have caught my attention. There are lots of other compounds. Most of them, though, are being studied in really very small studies, at least that are publicly known about. There's still interest in tolvaptan, the allopurinol and other xanthine oxidase inhibitors still of interest. There's a fairly large study funded by NIH underway, lots of other drugs, but I've tried to focus on the ones that I think are of interest. The only thing I am sure about is that, as has been our experience in the past 20 years ago, we will get lots more surprises when the results of these studies become available. So thank you very much.
So thank you for this magnificent presentation. I think we have some questions in the internet and also to the audience. Starting by the internet, please.
We have some questions of the internet very similar. I will try to mix the two questions. They are speaking about economic restrictions that maybe are the problem for no new developments in pharmacotherapy for one side, and they ask, if you have money, what of these drugs you will find to look for answers?
Okay, so everybody talks about economic restrictions and industry claims that it's so expensive to develop new drugs and so on. I must say I don't pay too much attention to that, and the reason I say that is that the US Food and Drug Administration recently said that new anti-diabetic drugs have to show cardiovascular safety if they're going to be marketed, and that's necessitated a large number of large clinical trials looking at cardiovascular outcomes in diabetics, and suddenly the money has been found to do that. So admittedly diabetes might be a more attractive target than heart failure, but my impression is that there's still a lot of development going on in heart failure. I've given you a flavour of that, and I'm not sure that there is a major economic restriction in drug development in heart failure, though I do think we all have to think about how to make clinical trials simpler and less expensive. What would I put my money on? Well, the only thing I've learned in doing clinical trials is that almost certainly the thing that you guess will be good will be wrong. But if I had to guess, I'd probably go for the dual-acting agent that inhibits the renin-angiotensin system and augments natriuretic peptides at the same time.
Thank you for your answer. Thank you.
Okay, any question from the audience? No? Let's move on.
John, what do you think of non-cardiac? What do you think of non-cardiac targets, like this targeting the skeletal muscle, like maybe even studying again the benefits of exercise training, anabolics, and this kind of thing?
Well, you know more about that than I do, and I must say I think of skeletal muscle problems and heart failure, maybe naively, I think of those as secondary, and that if you improve the patient's heart failure state, then everything else will improve. If they can exercise more, if they can be more active, the skeletal muscle function will improve. Now, I wouldn't preclude any approach, anything novel, interesting. It's worth trying.
But there comes, of course, a limit at some stage. Say we have suddenly a search of 8 successful drugs, and 8 being tested on the background of what we have now. Then there will be coming the big debate on which priority do we give these drugs, and then we should almost start to really impose kind of rules of do comparative research.
Well, my view about that is, wouldn't that be a wonderful position to be in, because we've never been in it so far. There is the potential to be in it with atmosphere and paradigm heart failure both running essentially simultaneously in the same patients. It's a dreadful dilemma, which I will never have 8 successful drugs at the same time. It just won't happen. But I think comparative research is very important, and that's what we're doing. I mean, atmosphere, paradigm heart failure is exactly that. It's always going to be a major challenge to deny people proven, life-saving, effective therapy unless the treatment that you're putting up against the gold standard shares a lot of similar characteristics. I really do think ethically that's a big hurdle that we'll have to jump.
Okay, time for a short question and a short answer, please.
As well as the studying new medications and treatments for heart failure, there's no research at all on using the drugs we know that work, whether it's ACE inhibitors. And I noticed actually you didn't mention ivabradine in that group. but it targets like heart rate lowering and has benefit in heart failure. But looking at something like combination therapy, like whether a Vabradine with lower dose of beta blockers or minute doses of ACE inhibitors have been tried. Like we have a lot of effective drugs that have been shown to work at one level, and there isn't obviously any pharmaceutical drug money that's going to go in trying to tease the drugs we use.
Well, you couldn't get me to do that trial. I would be absolutely loath to do a study in which I didn't try and titrate people to the proven dose of evidence-based therapy. That's how the trials were done. That's what showed benefits. In fact, with ACE inhibitors and with ARBs, we have 2 dose-response studies, both showing that bigger doses are better. So to me, that's an unethical study. Sorry.
Although you mentioned the doses in beta blockers, and as far as I know, MOCA was the only dose-response study. Is that the one you're referring to?
No. I was referring to ACE inhibitors and ARBs. I'm referring to ATLAS and HEAL.
You mentioned beta blocker dose response.
No, I didn't mention beta blocker dose response. I mentioned ACE inhibitor and ARB dose response, but the same is true for beta blockers. Why would you not try and titrate people to the proven dose of a beta blocker? How do you know that a lower dose of beta blockers is effective?
Well, because my understanding was there was controversy about whether it was a dose effect on beta blockers or a heart rate result on beta blockers.
Well, that's a controversy stirred up by a certain large pharmaceutical company.
John, you mentioned also that about replacing drugs, because we have a problem with compliance in our patients too, but you mentioned nothing about that. Can you please comment on that, and also about replacement? What type of drugs do you want us to replace?
I thought I did mention replacing drugs, and in fact, one of the reasons I'm very pleased to be involved in Atmosphere and Paradigm is because they're trying to do that. So they're not about adding another drug, they're about trying to replace what I described as gold standard, which is, by the way, in Allopril 10 milligrams twice a day. So I'm all for doing that, but it's hard to do because how can you deny? So let's say you came along and you said, I want to replace a beta blocker. How do you do that? How do you deny a patient a beta blocker? I don't think there's any doubt whatsoever that beta blockers are beneficial, so it becomes harder that's a harder study to do. So in Paradigm and Atmosphere, it was relatively easy because Paradigm, the molecule, is also an ARB, and in Atmosphere, the comparator is a renin inhibitor, and we, I think, are reasonably comfortable in thinking those drugs have similar efficacy. So I think in some circumstances you can do that. In other situations, I think it's ethically challenging, but, I just have one perspective.
Okay, let's move on.
Well, thank you very much, John. Now, the next speaker, I have the great pleasure to announce Magdi Yacoub from the UK. It says here, but I understand he also will tell us where else he is from currently. From heart transplant to new artificial pumps, will hearts be replaced by machines? I would like to add, we are about 25 minutes late, not more, but let's try to stay 25 minutes late overall because we started also late.
Thank you, Chairman. Ladies and gentlemen, my brief is to talk about heart transplantation and machines, and whether machines will replace heart transplantation. How do I start this? I have nothing to declare, and in this talk I will talk about definitions, and I will talk about evolution of heart transplantation and heart pumps in the clinic, position statement, where are we now, and perhaps try and predict the future, if I can. Now, if we define the heart, I'm reminded by William Harvey's description of the heart, very flowery, the heart of animals is the foundation of their life, the sovereign of everything within them, the sun of their microcosmos, and upon which all growth depends, from which all power proceeds. Now, the question is, can we reproduce all that, either by transplantation or by devices? Now, heart functions can be simply said that it is just a pump, but that is an oversimplification. It does many other things. Importantly, it is an endocrine organ, but one of the great features is that it is very tightly regulated, like many other biological processes, both in the short and long term, by being coupled to both the circulation and the neuroendocrine system. Can we reproduce all that? Now, I'll start by just talking about heart transplantation and my own experience in that field. And it is remarkable that only 60 years ago, heart transplantation was thought of as a fantasy for the future. And about 40 years ago, it was clinically introduced. Massive enthusiastic reception, followed by a moratorium because most or all the patients died within a short period of time. However, there has been steady progress, and currently we are starting to talk about long-term results. What do we mean by that? The expectations for the long-term results have moved quite a bit. I remember when it was just weeks, days, then we thought maybe we should treat it like cancer and talk about 5-year survival. Now we're talking about 20-year survival, and we're even thinking about age-matched normal population. Is that fair? I'll just show you what's happening. Currently, the transplant half-life is only 10 years. And that applies to both adults and children. And the conditional half-life for those who survive 1 year is 13 years. There is a constant attrition rate of 3.4% per year. Is that acceptable? Now, recently there has been papers published about 20 plus survival after heart transplantation, both from Stanford, this particular paper, and from our own center at Sheffield. And that prompted me to write an editorial, or was asked to write an editorial, about this great success of 20 years plus survival compared to what we were talking about in the early days. And in that editorial, I quoted Winston Churchill about is it the end of the beginning or the beginning of the end? And I thought it was the end of the beginning, because while there was every reason to celebrate that their heart transplantation has reached maturity, but 20 years plus, and that's where things mature. There were questions to be asked, because with maturity comes responsibility and accountability. And why was it then that only less than 20%, actually between 12 and 25%, survived 20 years? And we're talking about relatively young patients. And certainly it was not a match to the general population, particularly in children, and this constant attrition rate about what I was talking about. And the causes for that were obvious, and there were graft coronary disease, malignancy up to 100-fold, renal dysfunction, infection, and the important thing which came out, can we improve on that? Obviously, yes, we can. And there is personalized medicine that we can tell now which patient who is going to respond to what drug. Improving donor quality and availability with ex vivo perfusion. Importantly, early detection and treatment of rejection and cancer, renal dysfunction, newer immunosuppression, and we had the brilliant talk about newer drugs in heart failure. But immunosuppression is not as active as all that. But and the important thing, of course, was the holy grail of induction of specific immune tolerance, which the late Sir Peter Medawar talked about over 55 years ago. And Medawar's tolerance is obviously the answer, because all of the complications which I have shown you are due to non-specific immune tolerance, and we have not achieved this. It's interesting that Medawar himself talked about in an essay entitled The Glory and the Challenge of Science, that it is the great glory as it is the great threat, of science, that everything which is in principle possible, and he showed that it was possible, can be done if the intention to do it is sufficiently resolute. Obviously, we have not been sufficiently resolute, and we have not reached that point. But it could be done, and therefore transplant would benefit massively. What about heart pumps then? That has evolved in an almost meteoric way. Initially, the concept of mechanical support, from a balloon pump to ECMO to LVAD to total artificial heart, paracorporeal pulsatile, implantable, partial or complete, and pulsatile, and more recently into the continuous flow pumps. And initially, after a long period of delay, application in the clinic has increased dramatically, and as an estimate, which is an underestimate, over 40,000 devices has been implanted worldwide, and the Intermax registry shows that 4,000 per year are being implanted in the US, and as it was entitled by Jim Kirkland's article, talks about 4,000 a year and rising in the US. The technology, again, after a very long lag of using exactly the same substance, segmented polyurethane, almost for 60 years, with textured or surfaces. The valves were the same, the pulse source was the same. Initially there were ball bearings, but now there are suspended magnetic devices, and the greatest improvement came with the use of, paradoxically again, of constant flow pumps with the impeller pumps or the vortex pump. They're much smaller, and while the flow is continuous, it is remarkable how patients improved and results improved. There are still a lot of problems attached, but there are enhanced durability, and the recent trials have shown a survival in the two most recent trials with the HeartWare and HeartMate 2 of around 90% within 1 year. That has caused a paradigm shift in the application of the device, and originally it was being used for extremely sick patients, and these are the criteria which has evolved. More recently, the application of the Intermax criteria has shown that as we go along, we can define these patients at entry much, much better rather than class 3 and class 4 of the New York Heart Classification. And it's been shown quite clearly that the application has evolved tremendously from the rematch, for example. It was mainly in Intermax 1 and 2, the extremely sick patients. That category now, well, it's called crash and burn, or sliding rapidly on inotropic support. They are thought to be not suitable, and we should not wait until that. And with the advanced trial I've just talked to you about, it was Intermax 3 and 4 mostly, and now we're talking about a new trial called Revive IT, whereby the machines are being considered prior to inotropic support, hence the Revive IT. So this paradigm shift of trying to apply the device before there is severe damage is happening, and that's because of the improvement in the results, what I talked about, 90%. But we have to be conscious of the continuing relatively high long-term adverse events, particularly in terms of strokes and bleeding, and that, but the gastrointestinal bleeding as well, von Willebrand deficiency and so on. These are the currently available devices, and you will be aware the most recent ones are quite small, like the HeartWare, which can be introduced in the pericardium without a pocket, and with or without cardiopulmonary bypass, and all that has contributed to the improvement in the results. But the important thing is how these devices have been used and why. And the three main indications you will all be familiar with is bridge to this transplantation, destination therapy, and bridge to recovery, which to my mind is the most exciting application of these devices. And maximizing the chances of recovery can be done by combination therapy, pharmacologic agents to enhance reverse remodeling, followed by inducing physiologic hypertrophy, formal exercise training. There are ways of monitoring recovery which should be started actively 1 month after insertion of the device with minimal or no pump support to look at recovery. The recovery in itself and these programs, which should be active in the clinic, should be combined with basic science research, which should be an integral part of the programs. And it should be in search of targets for future therapy, and which we have heard about that. And if you look at the changes which occur with the devices, you find that they are massive. Some of them could be actually instrumental in the recovery. Others could be representing atrophy, and others could be just epiphenomenon. And these are like structural changes, like you can see here, in the size of the cardiomyocytes, either seen on a section or isolated cardiomyocytes. On the cell membrane, the density and distribution of the beta receptors inside the cell, the cytoskeletal system, both the sarcomeric and the non-sarcomeric, some go up, some go down, and importantly, the calcium handling proteins and changing in EC coupling, massive changes, as you can see here on this slide. And what are we going to do with all these data? Obviously, this represents a complex network, and the complex network cannot be dealt with a broom like this child is trying to do. But there are methods of dealing with complex networks, both in biology and on other branches of science, and determining which nodes are decision nodes. And that is massively important if we are to move forward in discovering the use of these devices and how do they interact with the heart. So in conclusion, I would say that the current situation is that heart transplantation is here to stay. And there is a massive need for methods of inducing specific immune tolerance and increasing the number of available donors. Heart transplantation continues to be a clinical tool and a source of inspiration. The progress in device technology and its application has resulted in paradigm shift in its application, in spite of the persisting problems which I've talked about. The most exciting area in all these programs is the positive interaction in the bridge to recovery, which I believe holds the secrets of heart failure. Thank you very much.
All right, at this moment we seem to not have questions through the web. Any questions, please? Now, in this whole context, Magdi, there's also cost discussions always when it comes to the devices. How do you see, let's say, 5 and 10 years from now, the cost going? Will it come down like CRT and ICD in the future? Is there any chance like that?
I think absolutely. Already the cost effectiveness of the devices, even trying to recoup the high cost of development, the devices obviously enhance quality of life and survival. And if we are to increase the application and the numbers, the prices should come down, and hopefully it will be just like what happened with pacemakers and other devices.
You? Well, if there is no question, you have a question, please. Go ahead.
So, Professor, I've recently moved to the Texas Heart Institute, and there I watched Bud Frazier and Billy Cohn put mechanical devices in cows, and they completely removed the heart, and these animals are living on the mechanical devices. Do you think we're ever going to reach that point clinically?
I think that's an interesting question. I myself still am a believer in the biological heart and every type of effort should be made to conserve the heart, even if there is so much fibrosis, vascular damage, etc., because a lot of that can be reversible. And this interaction between artificial devices and biological hearts is very intriguing.
Okay, thank you very much. Let's move on. So it is my pleasure to introduce Doris Taylor from the US to present the complete cardiac regeneration from stem cells. When will we get there with her Taylor heart?
Thank you very much. It's a pleasure to be here. I want to change gears a little bit, and the talks you've heard so far in this session have really been about clinically applicable alternatives, and I'm going to talk a little bit more about what I think is the future. And I do have a disclosure. I started a company a few years ago that actually is based on the research I'm going to talk about. But I started thinking about, I was asked to talk about when we'll get there. And I went back to fundamentals and pulled this slide that actually talks about the capital stages of moving a biotechnology forward. And like it or not, it has some relevant points that we need to consider. And the first is that the first step is to imagine an idea. The next is to incubate an idea, do preclinical trials, basic and applied research, then move obviously into clinical trials, and finally promote the idea to market it. And I decided to think about cell therapy as an analogy for this, because really, where have we moved with cell therapy, and therefore where might we go with something like a bioartificial heart? And I'll point out that we first started thinking about cell therapy for cardiovascular disease in 95 to 98. And in 98, my group was able to show the first functional improvement in myocardium. And 2001 to 2012, 12 years now, we've been doing clinical studies in cardiovascular disease with cell therapy, incubating those ideas. So we moved from preclinical studies immediately into clinical studies, and we're still there. And that only now, in the last year, have we reached a point that we may actually see approval of the first cell therapy for cardiovascular disease in 2012. So it's taken us almost 17 years to get to the point of our first approval. And I wonder we can look at gene therapies and realize they've followed a very similar timeline. And we can begin to ask questions what we might do to make a new technology move forward more rapidly. I also looked back at cell therapy, and as of spring of this year at clinicaltrials.gov, there were 471 studies currently registered with the term stem cells and heart, and 167 studies were actively recruiting as of the beginning of summer, June this year. So there are a large number of clinical studies underway, and that's increased fourfold from 2009, 3 years ago, when there were only 90 studies registered worldwide. And if you look, cells have been used throughout the continuum of cardiovascular disease, from early coronary atherosclerosis studies that are just now underway, through acute infarction to post-infarction heart failure, and even to later stage heart failure. But the biologic improvements have been somewhat small, although they're as large as some of the current pharmacologic therapies, with EF improvements of only 3 to 5%. So what are our opportunities, and what do we really need? Excuse me. And so what I said is, what can we do to begin to think about other therapies? And I would put forth that for end-stage heart failure, transplant is always going to be the definitive treatment, whether it's transplant of a device or a heart. And the question was, can we build a bioartificial heart? And so a few years ago, a number of years ago now, in about 2001, we said, can we imagine it? Can we imagine the idea of really building a bioartificial heart that's based not on mechanics but on really the features of the adult heart? And so we took a very simple approach and said, what do we need? We need cells, we need a scaffold, and we need a place to mature those cells in a scaffold, bioreactors that'll let us build something that's functional. And then we need to build a heart that can survive, can function, that is, can do more than just contract, can actually pump against a physiologic blood pressure. And that if we think about it, and we're going to use this for the long term, we also have to be able to build a heart that can self-regulate and repair. As you just heard Professor Acute talk about, the heart's not just a pump, it's also an endocrine organ. It's also a tissue that needs to be able to repair itself. So we developed a method whereby we could take cadaveric hearts, and all of you know this, and we could remove the cells from them, transplant cells back, and we could take a previously dead organ and actually revive that organ, albeit initially small hearts only, and actually get them to pump over time and be maintained for months in the laboratory. So we could take a cadaveric heart, wash the cells out, reimplant cells, and get it to live. So then the question came, how can we incubate this? What are the preclinical, basic, and applied studies we can begin to do? And the questions we've asked that I'm going to talk about today are, what can we learn about cardiac repair using this technology? One of the questions we've asked is, can stem cells ever mature in an infarcted heart? And what's the role of the extracellular matrix in cardiac repair going forward? And then obviously the real underlying question is, can we ever build a multi-chambered functional heart that can pump against a physiologic blood pressure? Well, first I want to just show you some of the basics of our decellularized extracellular matrix. You can see here a pig heart that's actually been completely decellularized. All the cells have been removed, and what remains is the extracellular matrix milieu. And you can see that there are valves that are intact. Here is the same pig heart valve. This is actually a rat heart valve to show you that even in an animal where the valve is very thin, the valve remains patent even after we remove all the cells. So we can remove all the cells and retain the structure, the gross macroscopic and microscopic structure. You can look here at an EM photograph of cadaveric heart and a heart that's had all of the cells removed. And you can see it literally looks like a tube of toothpaste where we just squeezed the matrix and removed all of the cells. What's turned out to be interesting is we remove all of the cells, all of the DNA is gone, but we retain a number of molecules, glycosaminoglycans that bind to the matrix, some growth factors that bind to the matrix. This is not just an inert bunch of collagen molecules that are sitting there. And in fact, when we look at the properties of the matrix actually changes the mechanical properties of the matrix. Young's modulus, something that bioengineers like to think about, differs completely in the right ventricle, whether we look at it in the longitudinal orientation or the circumferential orientation. That is, the matrix is anisotropic, just like the heart is. Same with the left ventricle. And if you look at female hearts here in white, male hearts in stripes, you can see the matrix itself has different properties based on sex. In addition, those properties change with age. Older hearts are stiffer than older matrix is stiffer than younger matrix. And in fact, we've shown that they change with age, with disease, with sex, with drugs, with all the parameters that we can begin to examine. And if you look at the number of molecules that are present in the extracellular matrix, this is from Karen Chrisman's work, you can see that there are a large number of molecules present, all of which affect the ultimate environment in which the cells find themselves. So we ask, can we use this to begin to understand why those improvements in myocardial performance after cell therapy have been relatively small? We can take uninjured or injured, this is an infarcted human heart, and we can actually remove all of the cells, create a decellularized human heart construct. We can actually slice these hearts to either give rings that on which we can transplant cells, or matrix flaps or patches. And you can see here that we can transplant cells on these and have those cells actually begin to integrate and cause synchronous contraction of the whole construct, the ring or the patch. However, what we began to study was in healthy versus infarcted heart. And what we found is that when we took human cardiac-derived cells, and this is work from Isabel Mosico, who came to my group from the CNIC in Spain and spent a year, she was able to create infarcted decellularized matrix or healthy matrix, transplant human cardiac-derived progenitor cells on that matrix, and show that if we looked at stem cell genes, here you can see c-KIT, a very prominent stem cell gene, is upregulated in the infarct. Islet-1, another stem cell gene. NANOG, an indicator of completely undifferentiated stem cell genes, go up in infarct, not in healthy myocardium. So in fact, and MESP2, a gene that pre-differentiates cells to become cardiac myocytes, does not go up in infarct, it only goes up in healthy heart. And in fact, if we look at other cardiac-derived genes, actin, connexin 43, transcription factors like GATA4 and NKX5, myosin heavy chain, and cardiac troponin, for the most part, they're all decreased in infarcted matrix. So here we are doing clinical studies where we're placing cells in this infarcted matrix, and they're not actually, they don't have the cues they need to be able to differentiate to begin to form functioning myocardium. Architecture also matters. We looked at intact extracellular matrix, that three-dimensional structure I showed you, versus matrix that we actually ground up and made into a gelatin. And you can see that if we look here, in this case, at NKX 2.5, at cardiac actin in green, and actually at cardiac troponin, that you see a much greater upregulation of these on the intact extracellular matrix than on the same molecules but in an inappropriate orientation. So architecture matters, composition matters, and it's not surprising. So now we have a test bed in which we can begin to actually evaluate different stem cell populations, plus or minus drugs, genes, etc., to determine what's going to happen. What's turned out to be really fascinating is we thought initially that we would be able probably to take pig matrices, decellularize those, and then use human cardiac stem cells, presumably autologous cells as the source of cells, to build a heart where we can biologic organ where we can begin to overcome some of these phenomena that Magdi just discussed. In fact, that we could think about building an autologous organ. Well, what we've recently been able to show, again with a group of colleagues in Spain, Paco Abiles, is that when we take mesenchymal cells and transplant them on human cardiac matrix, they receive signals that are phenomenal, that seem to begin to show them how to organize in a way that we don't see on non-human matrix. So we're going to have to revisit what's different about human and non-human cardiac matrix. The other thing that we can begin to realize is that this decellularized matrix contains vasculature. You can see here OCT of the LAD of a human heart, decellularized heart, showing the intact LAD throughout this vessel, throughout this construct. And in fact, you can see here blood that we infuse into this human heart, showing that even though there are no cells present, there are no cells lining these vessels, the blood stays within the vasculature. You can see a plaster cast here of decellularized heart versus cadaveric heart, showing that the vessels, the matrix is intact here. So we can actually begin to build things that in which we can feed the cells that we transplant. So we began to actually reinfuse endothelial cells into this acellular matrix, and we've shown that we can reline the vasculature with endothelial cells, small and large diameter cells. We can infuse cells labeled differently in the arterial and venous beds, and we can get them to cross, and we can actually recellularize the whole heart. We can recellularize large and small diameter vessels. We can even reline the endocardium and the trabeculae. And when we do re-endothelialize these, you can see that we actually greatly improve the contractility of these heart constructs, and that we now can move, albeit not to normal, but up to about 25 or 30% of normal control hearts. So the question then was, what can we do with this matrix? We started some in vivo experiments to look at ECM as a patch, because as many of you know, other matrices like alginate have moved forward in clinical studies here in Europe as a cardiac patch. So we did some experiments where we transplanted completely acellular constructs on the surface of infarcted myocardium, and you can see here that actually 2 weeks later we see what appears to be a vascularized construct full of cells, and that in fact where this patch actually is present, we see cells actively migrating from the underlying myocardium into the acellular patch. And we can look at these and see that very few of these cells are lymphocytes, very few are CD45 positive. It's not an inflammatory response. Very few of these cells are CD103 fibroblast-like. Some of these cells are VEGFR2 endothelial progenitor cells. Some are c-KIT positive cardiac progenitors. But the vast majority of these cells, by far, are a cardiac stem cell population of PDGFR2 positive cells. This acellular matrix is recruiting these cardiac stem cells into it and actually beginning to mature these cells in a way that we don't understand. And when we look at this acellular matrix as a patch, these are early studies, but you can see that in our small animal model, and we're moving to a large animal model now, we can improve ejection fraction with transplant of the ECM versus gel or sham treatment. So where are we? Well, we imagined the idea, we've done a number of preclinical studies, basic and applied research, and so now can we move into clinical studies? Well, in 2009, a group other than our own used a cadaveric donor trachea, admittedly a simple tube, that was reseeded with autologous cells and transplanted in an individual who is actually still doing well today. In 2011, this moved forward based on the decellularized trachea into an artificial trachea seeded with autologous cells in a patient who's doing well. So let me recap and say in 2 quick slides. Decellularized matrix retains biologic and architectural cues. It's an in vitro test bed. Recellularization is possible, but it's not yet optimized. But we may not need to fully optimize it before we transplant these constructs. We've now transplanted whole hearts that are not fully recellularized and watched cardiac progenitors migrate into these and actually begin to mature over time. So where are we? Well, if we compare this to cell therapy, where we started in 95 and today in 2012 we're here, I would say we started 10 years later. Very quickly we've moved forward. And already in 2011 and 12, there are clinical studies underway with simpler constructs of this matrix material. So I suspect it won't take 20 years, but I anticipate that within the next 2 to 3 years, there will be clinical studies, there will be first-in-human studies with biologically derived matrices. Now, because it's an election year in the U.S., I have to close with this slide and say that we have to be a little bit reticent and we have to be careful how we move forward. We used to talk about decellularized brain. I won't go there in this election year, except to say that caution, this machine has no brain. We have to use our own. We have to be careful how we move this technology forward, but I think we're at a very important cutting edge, and I just want to thank my colleagues as I end. Thank you very much.
Thank you very much. I don't know if we have any questions. We have one.
Yes, it's about the cost of this comparing with the traditional heart transplantation. What difference?
Well, of course, we don't know the answer to that yet because we're still early in this process. And obviously, there is a cost associated. I actually maintain that the rate-limiting step in this field will be getting enough cells to recellularize a whole heart, and so I suspect that much of the cost will come from obtaining and growing those cells over a period of time. So it'll be interesting to see as new cell technologies move forward. Already, we're working with some colleagues in Houston who've been able to go from 100 million cells to 100 billion cells in a 2-week period using some new bioreactor technology. So I'm optimistic that we'll be able to continually lower the cost of this.
We have a question from the audience.
Yes, fantastic lecture. Is there an issue of immunity here if you use a heterogeneous matrix with another human?
So what we've found is that the majority of the immunity seems to come from the cells, not from the matrix. And in fact, when we did some allogeneic studies, we found, and a couple of xenogeneic studies, we found that if we cover the matrix with autologous endothelial cells, immunogenicity goes away. Less than 5% of the cells that are mobilized in or around the construct are CD45 positive, lymphocytes, neutrophils, monocytes, macrophages. So less than 5% CD11B positive, CD19 positive. So we don't see that if we use autologous endothelial cells and essentially make the construct silent.
Professor Jakub?
Doris, the myocardium contains a variety of cells with different lineages. So what's the ideal source of cell?
So that's why we actually started looking at the matrix as a tool to differentiate cells down different lineages. And what we found is that we can get endothelial cells. The endothelial cells are von Willebrand factor positive, they're ENOS positive, they seem to behave in a reasonable way. We get some cardiomyocytes. We don't know the phenotype of the cardiomyocytes, whether they're atrial ventricular at this point yet. But I think your point is well taken. We're going to need large numbers of fibroblasts. We're going to need stem cells if these hearts are actually going to maintain themselves over time. And all of that is a hurdle, but we think given the appropriate milieu, we'll be able to generate that. And we're actively putting heterogeneous populations of cells in right now.
So where do you obtain them from, or what kind?
The endothelial, we get vascular cells from bone marrow or from blood. We've actually started working more recently with mesenchymal cells, either from adipose-derived tissue or from bone marrow. And we also have been working with a number of colleagues in the U.S., Tim Camp, Jamie Thompson, with human iPS cells and human ES-derived cells to see what mixtures of cells we actually need. So we don't know the best cell type yet. I actually think that will be the rate-limiting step in this technology.
Short question and very short answer also, please.
Oren Caspi, Israel. Is it possible to solubilize the decellularized matrix for future cell injection?
So we've actually done some of that, as has Karen Chrisman. We made the matrix into a gel, gelatin, where we do solubilize it. And Karen Chrisman's done some animal studies in vivo where she's actually shown that the matrix in that form is not myogenic, but it seems to be somewhat angiogenic, just like our patches are. We think that we actually get better myogenesis with the intact matrix, but I think your point is well taken. This matrix is probably still better than fibrin or some of the other matrices that are currently being used to retain cells in the heart.
One last question. I would like to take the opportunity here. You are saying you also do a company of this. Are your investors scared of the money to put up for safety? Because I don't think efficacy may be the real problem. You just stop at some stage. If you don't say efficacy, you haven't wasted that much money. The real wastage of money will come if your safety is not achieved. Because don't you think you need to have a 500 or 1,000 patient years of follow-up at some stage and really heavily in big numbers invest?
Well, for all the conflict of interest reasons that we heard earlier, I've taken a step away from the company, so I can't really speak to what the company thinks about right now. I do get royalties from the company, but what I can tell you is that we believe it's important to move forward in a stepwise fashion where we look at possibly not whole organs, but pieces of organs to answer those safety questions first, and show that the matrix is not immunogenic, show that the matrix is tolerized for a long period of time, that it can be maintained, that it can be, that a recellularized graft can be maintained for a really long period of time, and then begin to move forward. I think your points are very well taken, but the nice thing about this is that it applies to any organ or tissue, so we can begin to think about it for vessels, for valves, for a number of different constructs that aren't necessary, for a ventricular free wall patch, for a number of things that aren't whole heart.
Okay.
Thank you very much for this fantastic talk. It's like science fiction today.
I suspect the science fiction is to continue, so don't leave. Ken Dickstein is now showing something about new devices in heart failure management, recent developments, and promising technologies for the future.
Yeah, I have a, I guess it's an inherited hypersensitivity, allergic reaction to going over time.
We started really late.
I understand. I've been here for a while. So, but I hate to have people going over time and late. And I admire the diehards that are still here. But we're certainly going to shift gears now. I'm going to choose fifth and see if we can make it really quick. I'm going to just go through this in a fashion that will get you off to dinner a little earlier than you might have worried. I have to make a disclosure because what I did when I saw this topic was that I contacted some of the people I knew at different companies, and I asked them, send me 3 or 4 slides of your pipeline or promising technologies. And these are some companies that I've had some research interest with, and they did send me stuff. I'm not sure whether they really sent me their secrets and their pipeline stuff. A lot of it I had to end up modifying because some of it was commercial, and I tried to delete some of that and just give you an idea of what the companies sent to me. And this is just an arbitrary choice of 6 companies, and I will present a sort of quick potpourri of ongoing and future initiatives. based on these presentations. We've seen a very continuous development as the need, as this is Laennec listening, and you can see in his left hand the actual pipe that he proposed, and then he started using it. This is apparently what Laennec looked like later on. He developed this technology, but it was still based on clinical skills. He still had some contact with the patient, and I'm concerned that some of the emphasis that you'll just see in a moment really takes the clinical skills away from the clinician. This is from Boston Scientific, and they gave us a nice presentation and divided it into 3 different types of core products that they use, the LV lead, management and diagnostics, and then emphasized their interest in autonomic modulation therapy, and clearly all the companies are sort of interested in that. I'll just go through that in a little more detail with another company. But we are interested in CRT delivery, getting good quadrupolar LV leads that are programmable and they're over-the-wire delivery, and that make it possible for us to make sure that we're pacing the patient where we want to be. So that was a core product, which was a catheter. Like many of the other countries, they're interested in multiple sensors. The idea that you would sense things such as heart sounds, and we'll see that Soren puts a big emphasis on that, looking at the first heart sound as a method of contractility and force of contraction. Clearly, we would be interested in sensors that look at respiration, which increases during activity, and especially in heart failure, that look at other physiological parameters, such as heart rate or impedance, whether it's thoracic impedance or actually intracardiac impedance, and we'll see a device that looks at that. So I think these multiple sensors and putting it together in order to deliver better care is a focus that we saw throughout the responses. These technologies clearly could be either standalone or they could be in combination with another device that the patient required. Thoratec showed us some of their new technological developments, which are impressive. I think that Professor Jakob actually referred to the one that's the magnet, which is very important because it lifts up the flow, the pump, so that the gaps are larger and you're no longer resting on a pool of blood. And that permits larger gaps, permit much less erythrocyte trauma. It is not dependent on the pump speed. They can be adjusted. And also you can, if you want to, you can actually control the ramp speed and get a near physiologic pulse if you want that. Thoratec is also involved in percutaneous heart pumps, and I think that many of us feel the need for that very often in acute situations, patients who require support to get them through their complicated myocardial infarction or their shock situation, and we'd like to see these easier and easier to implant. So here we can see where the impeller is in this elastomeric capsule, which facilitates implantation, and it collapses. It goes down to a 14 French and opens up to a 24 French. This was something that one of my LVAD destination patients has asked for. He said, look, if I can put my iPhone onto a little thing, can't you load up my LVAD so that I don't have to have this opening and have this chronic infection that I have? And with this type of coil, where the AC power goes through, the coil induces a magnetic field, and that the source coil induces current in the capture coil, and that works very well, and that would solve a lot of the issues for the drive line that prevents us from letting the patient really get away and have an untethered period of time. Here we're talking about only 3 hours, but that would mean a lot, I think, to patients not to have that opening. Soren is emphasizing the first heart sound and its characteristics and its the way that it reflects the contractility of the left ventricle. And we can see that this is the technology which is beyond the scope of this this rapid shoot-through to discuss, but you can get very good optimization. And I think programming of our devices is so important. It's It's not rocket science, but it's not the most exciting part of the procedure. You don't get to put on green clothes and go into under the lights. But here you can see that we can divide it up into first VV delay and AV delay, that the amplitude of the actual first heart sound determines how we can get the most effective VV delay by looking over large. I think there's 14 different AV delays that are tried, and then you look and you see when you get the highest average amplitude, that would be the proper VV delay, and then you go through and look for this point of inflection, which is not something I've clearly understood, but I know that Jag was in the room, he explained it, should have explained it again to me, but that you can get the AV delay by going across and looking at all the various VV delays. So this is a continuous update which the patient is not involved in, and yet the CRT is being programmed continually for an optimal AV and VV delay, and I think that's a very important step. Medtronic presented some very interesting slides to us. Over here, I really do believe that the visualization of the venous system is very important, and here this is basically a two-plane software that permits you to get a three-dimensional view of the venous system, to place the lead not only in the most appropriate place, but because the movement is involved, you can see the point of the last activation of the left ventricle. So this is the implant system here is very attractive. There's also a system that in patients, especially with right bundle, where you would only be pacing the left ventricle and you would be avoiding unnecessary right ventricular pacing, which would be unfavorable. So it assesses intrinsic conduction, which is favorable. Then I just kept some of these in because for those of you who aren't very familiar with all the different ways that you can do autonomic modulation, it's quite impressive. There's many different areas that can be stimulated. You can stimulate the spinal cord, the vagus nerve, baroreceptor stimulation, and renal denervation. And I'm just going to show you a couple of those separately. There's a lot of interest, I think, in spinal cord stimulation. You stimulate at the sympathetic levels for the heart, T1, T5, and that should reduce cardiac sympathetic overload. It's another way of neurohumorally modulating heart failure management, which is what we've been very successful about doing pharmacologically. But if we can do it with a technological stimulation, that's very attractive. Baroreflex activation is interesting because we know as blood pressure rises, this procedure would mimic the increase in, when you mimic increase in blood pressure, you will then inhibit sympathetic activity, and you'll get enhanced parasympathetic activity. So this is a device that can be implanted and that will cause baroreflex stimulation, which sort of makes sense. Vagal nerve, obviously, is very available to us, and this can also be stimulated to increase parasympathetic activity, and this is another relatively simple machine. They're all looking a bit frightening to me. The renal denervation is what I think a lot of us have experience with. There's many centers. This has come out into clinical use now. It's not a procedure. It's not an implantation. I mean, it's a procedure, not an implantation of a device. So that you can, in good hands, that you can ablate the renal nerves, and you will then reduce sympathetic activity as well as the broad level of renin, angiotensin, aldosterone activity. So that's a very attractive, and the results that I've seen are very promising, I think, for renal denervation. Biotronic also emphasized a very integrated solution, looking at multiple sensors and feedback from the patient and putting this all together. They do have a MRI-friendly CRT device, which was something that I particularly felt was an advance. It's something very often feel we'd like to do on our patient. It would add diagnostic and therapeutic implications, and we would like to see more and more MRI-friendly devices. Intracardiac impedance. I think most of us are familiar with intrathoracic impedance. And that is intuitively attractive, does have certain limitations. Clearly, patients with pleural effusion or pneumonia will also develop changes in impotence, but this is intrathoracic. I mean, this is intracardiac. And you can see over here how the ventricular volumes change in systole and diastole. As the heart fills up, the impotence will increase, and in the filling phase it will go down, so that it's an interesting concept that if we could really get into looking at left ventricular volumes and follow that on a beat-to-beat basis, then clearly we'll be able to use this perhaps also to modify and the program and get optimal AV and VV delay. And you could look at that during the actual procedure. You might be able to do that while you're implanting your lead and seeing if you're at the optimal space. So I think intracardiac impedance is a new concept. I'm sure there's some promising data, but I think that this will be developed, and I find the concept attractive. St. Jude has experience with pressure measurements, as you will know from previous trials, that have had certain limitations perhaps in the protocol, but the concept is attractive, that you could percutaneously through a femoral vein deliver a PAP, a pulmonary artery pressure sensor that would go into the left pulmonary artery, descending pulmonary artery, and that you would then be able to see the development, rise and fall of pulmonary pressures. And this is a concept that I think is in practice, has been tested, but I think it would have to be developed because the results have not been as promising as we'd hoped. But I think the concept is useful, and it's certainly less invasive than the next generation, which is a left atrial pressure sensor. I think that all of us would prefer, if we could, since the left atrium is so, left atrial pressure and dyspnea are so related, we would expect that to change very quickly in a patient who's decompensating. We would like to see a left atrial sensor, but of course that's not an easy task because you've got to do a transeptal puncture, and the devices and the techniques are getting less and less invasive, and the experience is better and better. You can do it from a femoral or a superior approach or a lead transfer. But the idea that we might get sensors in the left atrium that we could read and be sent back from the patient, I think would empower physicians in making their decisions. I'm almost finished, Stefan, so I'm doing real well here. This is another one. I just saw this last night. This is not electrical, but Bill Abraham gave a talk at the press conference you were at, which I just thought was great. There's hundreds of devices. We could be talking about sleep apnea devices too, but this one I found particularly attractive because I have a real interest in transmural anterior wall infarction. And this idea that you can put this parachute in the aneurysm, which has a polymer cover, and you can restore the conical shape, and you lose the loss of contractility or contraction into the aneurysm, and that you physically prevent the adverse remodeling that we see so often in patients with transmural anterior wall. And there's a very good experience with this. It gets endothelialized in about 10 to 14 days, and it's not that complicated, apparently, to place in good hands. So this is an idea. I'm going to finish in 30 seconds. I just want you to remember placebo's evil twin brother, and that is nocebo. Which is, when I see patients with devices, it can go both ways, and it can go both ways in the same patient. There's an enormous placebo effect when you put a device, but there's also another effect which is very frightening to the patient. Sometimes they might not expect that in the very beginning. And I think it's so important that the way that we give registration and the way that we, the EMEA has, in Europe, we have 22,000 devices, separate devices registered, very often on conditional registration without adequate post-marketing surveillance. I think it's important that we understand the implications psychologically of filling patients up with devices. I was very impressed when Michael Hill showed me this slide, and he thought, and I think this is the way that the advanced technicians really think we can do this, and this is true. we could do these kind of things. We can get biomarkers, we can get rhythms, we can get pressures, we can look at saturations of blood, and really develop a very sophisticated distributed medical device, which is sensing most of the physiological parameters that we can treat. And I'm sure that as time goes on and these devices become more and more sophisticated, we're going to see those. And I think we're going to have to face both the technical, economic, and ethical issues. So my final slide is from Heberden, who you know described angina pectoris and talked about the treatment, which was one of his patients was nearly cured after 6 months of sawing wood for half an hour. So maybe, a chainsaw might be a method that we could actually get patients more active, simpler ideas. And let's not forget that the good pharmacology, the good clinical management, the living adjustments that I think we can make in our patients. And as we become more and more dependent on technology, I think this is going to be a very challenging balance for all of us to follow, because as you can see, there's an explosive development in this field, and I'm really sorry that it's so late in the day, but I admire all of you who've stayed through this session. The first 3 speakers were certainly worth being here for. Thank you very much.
Questions from the audience? I have one final question. Yesterday someone said that in the short term, renal denervation would be the first, the major hit in heart failure. Do you agree with this?
I might. The data that I've seen has left me with my jaws open sometimes. And I'm trying to encourage the people that I work with to get involved so I can get some hands-on experience with this. Because it makes sense, so it's intuitively attractive. The results are promising. The patients go home without pieces of metal in their body, and it's a treatment, which I find, that's certainly promising, and it may be, as you say, an important part of our management armamentarium in the future. Thank you.
We had a good session. Started late. We are sorry, but we are thankful to the speakers and the audience. Thank you so much.
Thank you.